So this this lecture is an introduction into kidney transplantation. It's an overview. If you guys have any questions about any specific topic that I discuss within this lecture, feel free to jump in and ask me any questions throughout the talk. Okay. All right. So the objectives of this presentation is to explain to you guys why renal transplantation is considered the optimal treatment for end-stage renal disease. I'm going to give you an introduction into the referral to transplant center, when you should be considering to refer a patient to for transplant evaluation, what the process is like, the transplant evaluation process, and what are the contraindications for a kidney transplant. I'll give you an introduction into immunosuppression therapy, what the most common regimens are, and their toxicities and the drug interactions. And then I'm going to end the talk with post-transplant complications, including malignancy and infections. So once a patient is diagnosed with end-stage renal disease, there are three potential options for treatment. They can receive hemodialysis. They could either go into peritoneal dialysis, or they could receive a renal transplant. These are the three methods of renal replacement therapy currently available. Most patients in the United States, according to the United States Renal Database System, 63% of patients were receiving hemodialysis in 2018, as compared to 7% of patients were receiving peritoneal dialysis, and about 30% of patients received a renal transplant during that year. Renal transplantation is actually considered the best treatment for end-stage renal disease, and these are the reasons why. Receiving a kidney transplant significantly improves the quality of life of patients. It increases the life expectancy, and is also cost-effective. So how does it improve the quality of life? Well, the main thing is that they're going to be free of dialysis constraints, particularly the patients that go to hemodialysis. They go to a center 3 times a week for 3 to 4 hours each time. So that significantly limits what they're able to do. It limits the ability for them to work and to travel. Once they receive a transplant, they're free of those constraints. A large number of patients are able to return to work. There are some patients on dialysis that continue to work, but most of them tend to go into disability. But with a transplant, a large number of patients return to work. There's freedom to travel, because you don't have to worry about finding a place where you can get dialyzed when you're traveling. There's a relatively unrestricted diet. You guys know that people who are ESRD or advanced CKD, they have a very restricted diet, but once they receive a transplant, that is not the case. The only thing is that we ask them to avoid these fruits, because these fruits can interact with the ProGraph and affect the ProGraph level significantly. Also, there is restoration of fertility. Once a patient has advanced CKD or end-stage renal disease, it is very difficult for them to have children, to get pregnant. But with a transplant, you have restoration of the hypothalamic pituitary ovarian axis, and it's much easier for them to get pregnant. When it comes to mortality benefits, if you compare patients who receive a transplant, this is a study that compared more than 20,000 renal transplant recipients as compared to more than 40,000 patients on the wait list. And when you look at that, patients who are transplanted, they have a higher mortality for the first 3 months after transplant as compared to those on the wait list. But once they pass those first 3 months, the mortality risk drops significantly, and patients with a transplant survive much longer, to the point that those who receive a transplant had a 20 projected years of life, as compared to 10 for patients who remain on the wait list. So transplant doubles the life expectancy of the patients. And that benefit is true throughout all age ranges. So if you look at young patients around 20 to 24 years old, they may be expected to live somewhere between 15, maybe 20 years on dialysis. But if they receive a renal transplant, they're expected to survive more than 40 years. If you look at somebody around over the age of 50, they may survive around 8 years on dialysis with a transplant that they're expected to survive 20 years. And that benefit is also observed in the elderly population. If somebody's over the age of 70, they may survive somewhere between 3 to 4 years on dialysis. And then with a transplant, they can survive 9 to 10 years. So transplant doubles the life expectancy of the patients throughout all ages, all age groups. And then I told you that transplant is cost effective. Most of the cost for transplant is concurred at the beginning after the surgery. So this was Medicare expenditure and ESRD population. For those on hemodialysis, and this is per person per year. So for those on hemodialysis, Medicare spends around $90,000 per person per year, as compared to somewhere around $35,000 for people who receive a transplant. So significantly cost effective for patients to get a transplant as opposed to remaining on hemodialysis. Or peritoneal dialysis is also fairly expensive. Despite the fact that transplant is considered the best treatment, only about somewhere between 15 to 18% of patients, of dialysis patients, are actually on the wait list. And that was between 1999 to 2016. So as a result of this, Medicare, that's like one of the requirements for dialysis unit. They have set the bar of 20%. A dialysis unit is expected to have at least 20% of their patients listed for transplant nowadays. And because we have recognized the benefit of transplant, the patients that are being waitlisted has increased over the years significantly, but we still have a long way to go. So this was at the end of last year, there were about close to 100,000 patients waiting for a solid organ transplant. Of those, the majority were waiting for a kidney transplant. 92% were waiting for a kidney transplant. Over the years, we have made significant progress. And as you can see, over the years, we were increasing the number of transplants that was being performed. Every year we were doing better, but then in 2020, because of the pandemic, that number significantly dropped because most centers stopped doing transplant at the beginning of the pandemic for the first 2 to 3 months. So there's a significant drop for 2020. So where do we get these kidneys? Most kidneys come from a deceased donor, 66%, and about 34% come from a living donor. So when should you be thinking about referring your patients for transplantation, for transplant evaluation? So as soon as you recognize that a patient has progressive CKD, you should start preparing them for renal transplantation, having the discussion about it. Ideally, you want your patients to undergo transplantation before they initiate dialysis. So it's important that they are referred early, because since there's such a large number of patients waiting for transplant, especially in New York and the East Coast, the wait time is around 5 to 7 years. So you want the patients to start gaining time as soon as possible. You should consider referring a patient for transplant evaluation if their GFR is less than 30 and the disease course is so rapid that you expect that they're going to require dialysis in 1 to 2 years. Even though you're referring them with a GFR less than 30, the patient is actually not eligible to be listed for transplant until their GFR is less or equal to 20. So that's why we said that if you recognize that the disease course is progressing fast and they're going to be on dialysis in 1 to 2 years, you should refer when the GFR is less than 30. That way, they're already part of our list of patients. Even though they're not on the list, we're keeping track so that they can start gaining time as soon as their GFR drops below 21. And this is the reason why you want the patients to get transplanted as soon as possible. So patients who get transplanted preemptively or who do not spend much time on dialysis, both the patients survive longer and the graft also survives longer. So this study compared people who were on dialysis for less than 6 months compared to those who were on dialysis for greater than 24 months. And they looked at the graft survival. Those who were on dialysis longer had a significantly lower graft survival. At 5 years, it was 58% on those who were longer on dialysis, 78% on those who spent less than 6 months. And at 10 years, it was 63% for those who were less than 6 months on dialysis versus 29% for those who were on dialysis for a longer period of time. So you want your patients to get transplanted as soon as possible, and ideally preemptively before they even start dialysis. So when we get a patient for evaluation, we do a very thorough history and physical. All the patients get chest x-ray, EKG, and echo. Some may or may not get stress tests depending on their medical history. We do blood work, we do HIV-appropriate cancer screening. They meet with our financial coordinator, social worker, and depending on if they have any psych history, they get a thorough psychological evaluation. And then they may see other consultants depending on their medical history. So what are the absolute and relative contraindications for transplant? So if a patient is expected to have to survive less than 3 to 5 years, this is more of a relative contraindication. If you look at the patient, you do not expect that person to live more than 3 or 5 years. You just have to weigh the risk versus benefit of transplantation, and you may consider not transplanting the patient. If a patient has cirrhosis of the liver, also depends on the severity. If they have advanced decompensated cirrhosis, that is an absolute contraindication. The only way they can get a kidney transplant is if they also get a liver transplant. But if they have a mild, moderate cirrhosis that is compensated, they could get a kidney transplant alone. Anybody with an active infection, they need to clear the infection before they're considered for transplantation for obvious reasons, because they're gonna get very immunocompromised with the medication. So they could die of sepsis if you transplant them with an active infection. Patients on active tuberculosis treatment, they need to complete the treatment first before they're eligible, because the treatment will interact with the transplant medication. For HIV patients, their HIV has to be controlled, the viral load undetectable, and the CD4 count has to be greater than 200 for them to be eligible. If they have a CD4 less than 200 or detectable viral load, they will not be eligible for transplant. If a patient has advanced COPD requiring home O2 treatment, that is an absolute contraindication. They could potentially get a kidney if they are eligible for a lung transplant. So they could get a combined lung kidney transplant. If a patient has severe CHF with an EF less than 30%, and this is not improved with medical or surgical treatment or dialysis, like sometimes patients get referred to us very early. Either they're not on dialysis or they started dialysis recently and their EF is very low. What we do is we wait for them to be dialyzed for like 3 months or so, and then we repeat the echo. But if the EF is persistently less than 30% and it cannot be corrected with treatment, the patient is not eligible for a kidney transplant alone, but they may be eligible for a combined heart kidney. Any patient with an active or recent malignancy, they're not eligible for transplant. Later on, I'm gonna show you what is the wait time depending on the malignancy. If they have a history of non-compliance, they must show that they're compliant for at least 6 months before we consider them for transplant. If they have active substance abuse, they need to go to rehab and they need to be off drugs for at least 6 months. And that does not include marijuana. Marijuana, the patient who can get transplanted, they will be eligible for transplant. But any other drug use, they need to be clean for at least 6 months. If a patient lacks cognitive capacity and they cannot make decisions or sign consent, this one is, it varies depending. Like if it is a patient with a history of mental retardation, but they have very good social support, their parents or siblings take care of them and help with their medications, we do transplant those patients. But if it is an elderly patient, with dementia, with advanced dementia and they lack capacity, we would not consider these patients for transplant. Extreme morbid obesity, BMI greater than 45. So these patients would have to go to bariatric surgery, lose weight before we can consider them for transplant. And if they have severe PVD, peripheral vascular disease, the patient may not be eligible for transplant. This one, we discuss it on a case-by-case basis with the surgeon and see whether they're able to they have enough vessel where they can do the anastomosis for the transplant. So when it comes to malignancy, for most cancers, patients have to wait somewhere between 2 to 5 years, depending on the cancer type. If a patient is found to have an incidental renal cell carcinoma, for instance, we often do CAT scan just to look at the anatomy and the vessels of the patient. If we identify a small lesion that is unilateral in one kidney, small, and the patient didn't have any symptoms, those patients do not need to wait at all for transplant. They can proceed with transplant without any wait time. However, if the CAT scan was done because the patient had hematuria or had any symptoms and they identified renal cell carcinoma, depending on the size, they may have to wait 2 to 5 years. If it is like very large and invasive, they need to wait a minimum of 5 years. So when it comes to the other cancers, breast, colorectal, bladder, uterine, most of them have to wait between 2 to 5 years, 2 years if it is localized and in situ, 5 years, a minimum if it is more invasive. For prostate cancer, if it is very localized, early stage, you may not need to have any wait time. But if it is more invasive, they have to wait at least 2 years. For melanoma, they have to wait 2 years if it is in situ. If it is invasive, they have to wait 5 years. But for melanoma, there's always a wait time, 2 to 5 years. For non-melanoma skin cancer, if it is localized, there may, and very small and localized, there may be no wait time. But if it is more invasive, they may have to wait 2 years. But melanoma, there's a longer wait time. For the blood cancers, leukemia, lymphoma, there's a minimum of 2 years wait time. If the patient has a history of multiple myeloma, that is transplant, most centers will not transplant these patients with multiple myeloma or myelodysplastic syndrome. That's an absolute contraindication because there's very high risk of progressing to other hematological malignancy. So this is how the surgery is done. So the native kidneys stay in place in their location. Then the transplanted kidney, they usually anastomose the renal artery and the renal vein to the common iliac vessels or the internal iliac vessels. They usually use the donor ureter for the anastomosis to the bladder, but if it is too short or there's issues with the donor ureter, sometimes but they may take the recipient native kidney ureter, they may take a piece of it and use it for the anastomosis. The kidney goes, usually we actually put it on the right side in the right lower quadrant, but depending on the anatomy, sometimes they may do it on the left lower quadrant. So immunosuppression. In order to understand how our immunosuppression works, you need to understand how T-cell activation works. So this is your T-cell. You have a T-cell receptor, and then you have an antigen presenting cell that comes in and has depending on the type of cell, it may have an MHC1 or MHC2, major histocompatibility, complex 1 or 2, which in humans is called HLA, human leukocyte antigen. And the MHC molecule presents an antigen to the T-cell receptor. So you have the T-cell receptor, but you also have a co-stimulatory signal as well. There's a molecule in the antigen presenting cell, which varies depending on which antigen presenting cell it is. And there's one on the T-cell. And you need both of these signals for T cell to be activated. Once these signals get active, you have an influx of calcium. You have increased calcium inside the cell. The calcium will lead to activation of calcineurin in the cytosol. And then you have this molecule, which is a transcription factor in the cytosol called nuclear factor of activated T cell. Normally it lives in the cytosol phosphorylated, but then when calcineurin gets activated, it dephosphorylates this molecule, and the molecule goes into the nucleus and transcribes the interleukin-2 gene. So you have increased interleukin-2 production, and then the interleukin-2 goes into the cell surface and activates the interleukin-2 receptor. This leads to a cascade of events that in the end, it leads to the cell entering the cell cycle. So then the T cell replicates, and you have T cell replication and proliferation. So our immunosuppression works on different aspects of these pathways. So when we have different induction medications, one is called thymoglobulin. Thymoglobulin, essentially what it does is that it kills all your cells, all the T cells. So if you don't have T cell, obviously you're not gonna have this activation. So that's why they're called T cell depleting agents. And then you have another one that is called baxilicimab, that one does not kill your T cell. It just blocks this receptor, the interleukin-2 receptor, and prevents the cell from entering the cell cycle. So for the induction therapy, we tend to use the one that kills all the T cell for patients who are very highly sensitized and they're at risk of developing rejection. We tend to use the T cell depleting. In the baxilicimab, we tend to use it more for people who are lower risk. Then we have the maintenance immunosuppression. We have the calcineurin inhibitors. You have cyclosporin and Prograf. They work here. They inhibit the activation of calcineurin. So if you don't have that, there's not going to be activation of transcription of the interleukin-2 gene. So this is where they work. The steroid also prevent this nuclear factor activated T cell from entering the nucleus. So this is another place where you're blocking the T cell activation and proliferation. Rapamycin works, it's an mTOR inhibitor. mTOR is part of this cascade of events that I mentioned here in order for the cell to enter the cell cycle. And then mycophenolate and azathioprine, Imuran, they're anti-metabolites. So they work by blocking the cell cycle from progressing. So these are the different pathways. And then you guys may have heard of one called belatacept, which is an injectable one that patients receive like once a month. This one blocks this co-stimulatory signal here that I mentioned before. So with the newer immunosuppressions, we have made remarkable improvement in decreasing rejection and improving graft survival. So when we first started doing transplant, they used to do just mercaptan-6, mercaptopurine, prednisone, radiation, and at the time there was 40% 1 year rejection and 80% 80% one year rejection and only 40% 1 year graft survival. Then as we develop the newer immunosuppression, you can see that the grafts cross and you have significant improvement in 1 year graft survival to the point that graft survival is over 90% 1 year graft survival. And the risk of rejection at 1 year is around 5%, 5 to 10%. And this is because of the newer immunosuppression, the tacrolimus, mycophenolate, and thymoglobulin. When we used to have only cyclosporin, graft survival was only 80%, and the risk of rejection was closer to like 40%. And as we introduced tacro and mycophenolate, it approached 90. So because of that, most people get tacrolimus. More than 90% of patients get tacrolimus. Most of them get mycophenolate instead of Imuran, more than 90%. And almost all the patients get steroids, around 70%. So most patients are on a triple regimen of tacro, mycophenolate, and prednisone. So these are the toxicities for the medications. Tacrolimus, both CNI, tacrolimus and cyclosporin, they can cause nephrotoxicity, and they also can cause both neurotoxicity. The nephrotoxicity, you can have acute and chronic. The acute is more of a vasoconstricting effect, that you have global vasoconstriction. So you may see an increase in, a decrease in the GFR with these medications. And then the chronic causes more of, causes more like fibrosis over time. Tacrolimus is associated in cyclosporin are both associated with hypertension. Tacrolimus is associated with hyperglycemia, and there's a high incidence of post-transplant diabetes because tacrolimus is actually directly toxic to the islet cells in the pancreas. That is not observed with cyclosporin. Tacro is associated with hair loss, and cyclosporin is associated with hirsutism. Cyclosporin is also associated with hyperlipidemia, which is not seen with Ticro. Mycophenolate, one of the most common side effects are cytopenias and GI toxicity. These patients often develop diarrhea. That's a common side effect. And the cytopenia, most frequently leukopenia. Mycophenolate is contraindicated in pregnancy because it can cause birth defects. So if a patient, we highly encourage patients not to get pregnant for the first or second year post-transplant. But if they were to have an accident and they get pregnant, then we have to discontinue the mycophenolate and we'll start them on Imuran. So if you have a transplant patient that gets pregnant, you should immediately discontinue the mycophenolate and then just let the transplant nephrologist inform them of that so that they can adjust the immunosuppression regimen. Steroids, you guys know the side effect of steroids: osteoporosis, weight gain, hyperglycemia, post-transplant diabetes, and there's much more. Sirolimus is associated with hyperlipidemia, cytopenia, GI toxicity, but an important one is proteinuria. And it also can be associated with pneumonitis as well. You can get RAPA-induced pneumonitis. So if a patient develops like some kind of pneumonia and respiratory illness while on sirolimus, they'll need to be switched to another regimen. All of these medications are associated with an increased risk of malignancy, post-transplant lymphoproliferative disease or lymphoma, and infections. The reason why they're associated with this is because the way they work is by compromising the immune system. So you have decreased immune surveillance, so they have a higher risk of malignancies and infections. So the drug-drug interactions, CNI are metabolized by the cytochrome P450 3A4. So any medication that interact with this will increase or decrease the level of your CNI. So azole, antifungals like fluconazole, clotrimazole, macrolide, antibacterials like erythromycin, clarithromycin, calcium channel blockers like verapamil and cardizem, protease inhibitors, and antiarrhythmic drugs like amiodarone and dronedarone. They're inhibitors of the cytochrome P450, and since they're inhibiting the metabolism of the CNIs, you're gonna have increased level of your CNI. It's not that we cannot use any of these drugs. We highly prefer not to use them because then that means we have to adjust the dose of the Prograf. But if you have a patient with arrhythmia and they absolutely need to be on this antiarrhythmic, we will do it. We just ask that we're okay with you initiating it, but communicate with us so we can adjust their CNI dosing. Protease inhibitors is a strong inhibitor. There's strong interaction. So we highly try to avoid patients from being on protease inhibitors when they're getting a transplant. So like HIV patients, we tend to refer them to infectious disease so that they will switch them to a non-protease inhibitors regimen. But some patients have resistant strain of HIV and they absolutely need to be on a protease inhibitors. So in our center, we try to avoid using CNI. We may use belatacept, which is the one that I told you that blocks the co-stimulatory signal. So we may use belatacept instead. But if the patient is very sensitized, Belatacept has a higher risk of rejection, so we may leave them on tacrolimus. It's just going to be incredibly difficult to adjust the dose. Some patients get you may find that a patient is getting 0.5 milligrams once a week of tacrolimus, and it's because of the strong interaction between the protease inhibitors and the tacrolimus. So if you're going to start the patients on any of this, fluconazole, verapamil, cardizem, or any of this, just have a discussion and inform their transplant nephrologist first so that they can adjust their CNI dosing. Anticonvulsants like phenobarb, carbamazepine, antitubercular drugs, INH, rifampin, they stimulate the cytochrome P450, so that leads to increased metabolism of CNI. So you're going to have decreased level of the CNI drugs if you start them on these medications. So post-transplant complications, the most common cause of death in our patient is the same as in the general population: cardiovascular disease, 24%. That is followed by infections, 16%, and then malignancy, 12%. So infections, what kind of infection can you expect to see in patients? That varies depending how far out they are from transplant. So during the first month of transplant, from 0 to 1 month, most infections we observed are post-operative complications like line-related infections, UTIs, healthcare-associated pneumonia, surgical wound infections. You may also see reactivation of herpes simplex 1 and 2. And you may observe candidiasis, oral or esophageal candidiasis. After the first month, between month 1 to 6, that's when you start seeing the opportunistic infections like PCP, aspergillus, toxo, strongyloides, mycobacteria. You may have VCV, CMV, EBV reactivation. You may see reactivation of hepatitis B and C. This is when you may see the early onset of BK virus nephropathy. Usually the patients may have viremia. That's why we tend to monitor their BK virus level once a month, because viremia precedes nephropathy by 8 weeks. So if we can identify the BK viremia, we can intervene before it affects the kidney. You may see listeria, and then you can see endemic mycosis and cryptococcosis during the first 6 months. Once you go beyond 6 months, you start seeing like the regular infections as you see in the general population, more community-acquired infections like upper respiratory infections, pneumonia, UTI, gastroenteritis, influenza. You may see CMV, viremia after 6 months, and that's because the CMV prophylaxis is usually for the first 6 months, and then we discontinue it after 6 months. So this is a time where the patient, especially if they're high risk for CMV, this is a time when you may see it reactivate once we discontinue the prophylaxis, the Valside. You may see late onset BK virus nephropathy after 6 months, and you may observe cryptococcosis. So these are the medications that we use for prophylaxis, infectious prophylaxis. So for the Bactrim is used for PCP prophylaxis. That's the first one that we preferred. We usually use it for 6 months. In some centers, they use it for a year. If a patient has a history of HIV, they stay on that for lifelong. If they have a contraindication because they're allergic to sulfa or because of hyperkalemia, we may use Mepron, atovaquone, or we may use Dapsone. For Candida prophylaxis, we often in our center we use nystatin, but you can also use clotrimazole. We use fluconazole for patients who get a pancreas transplant. It's usually for 1 month. And then for CMV prophylaxis, if they're intermediate or high risk, they'll be on Valside for 6 months. Lower dose for intermediate, higher dose for high risk. Intermediate means that the recipient has been exposed to CMV in the past. So they have CMV IgG. They have seen CMV. So regardless of what the donor is, if the recipient has seen CMV, they're considered intermediate risk. If the recipient has never seen CMV, they're IgG negative, and the donor is positive, that is considered high risk for CMV, and they tend to get a much higher dose of Valside. If neither the donor nor the recipient have ever seen CMV and they're both negative, Then we do not give valside because they don't need CMV prophylaxis. They need HSV prophylaxis, so they get acyclovir for HSV prophylaxis for 3 months. Malignancies is more common in transplant patients. The most common malignancy in our patients is skin cancer, lymphomas, renal cell carcinoma, and Kaposi's. Skin cancer, patients with a transplant have more than 20-fold increased risk of developing skin cancer, and it's non-melanoma skin cancer. We usually have our patients see a dermatologist once a year just for a regular skin checkup. So that they can identify it early if they were to develop it. Patients with a transplant has a 2-fold increased risk of GI malignancy, 15-fold increased risk of developing RCC of the native kidney, not of the transplant, more than 20-fold increased risk of lymphoma, and more than 20-fold increased risk of Kaposi sarcoma. So why is cancer more common in transplant patients? First of all, immunosuppression agents can cause DNA damage and may interfere with the normal DNA repair mechanism. In addition, they have impaired immune surveillance. So as you guys know, the immune system, if it identifies an abnormal cell, it will attack it and eliminate it and clear it out before it progresses. And then they also have impaired immune activity against viruses with oncogenic potential. So all these viruses are associated with this malignancy, EBV with lymphoma, HHV8 with Kaposi, HPV with cervical cancer. So patients with a transplant have a higher risk of this malignancy because they have decreased immune activity against these viruses. So as you guys know, like we tend to use the same cancer screening as the general population for our transplant patient, except we also have them see a dermatologist. As you know, they change like the pap smear, they change they change the frequency. So now it's like 3 to 5 years depending. But that is in the general population. In transplant patient, that has not been specifically looked at. So I don't totally feel comfortable with the transplant patient waiting 3-5 years to be screened for cervical cancer, because transplant patients do have a higher risk of cervical cancer because they have impaired clearance of HPV. So it's something to take into account. I tell my patients, look, they change their recommendation. You should just continue seeing your gynecologist once a year. They'll decide whether they're gonna do the pap smear or not, but I don't think they should be spending 3 or 5 years without seeing a gynecologist. They should see them regularly, and they should get all their other cancer screening as recommended. In addition, we tend to screen for renal cell carcinoma. The guidelines currently do not recommend doing that, but we do it in our transplant population. We used to do imaging of the native kidney every 5 years. And now we're changing it a little bit to every 7 years to decrease the number of studies that they're getting. And then finally, I showed you before that we're doing very well with the first year graft survival, more than 90% survival at 1 year, but we're actually not doing so well when it comes to long-term graft survival. So this is a graft failure at 10 years, and it's close to like 60% graft failure at 10 years. So as you can see, over time, graft failure significantly decreases. And why is that? Why are we not doing well with late kidney graft failure? The reason is because there's multiple factors that can cause graft failure. It's not necessarily just related to the rejection itself. We're doing great with 1 year rejection. And that's why we're doing very well with 1 year graft survival. But then when it comes to late graft failure, this can be alloantigen dependent or alloantigen independent. So alloantigen dependent has to do with rejection. If they have the prior sensitization, there may be suboptimal immunosuppression. The patient may be non-compliance with his medication, and maybe just a higher risk patient who has ongoing humoral injury. So all of this will contribute to late graft rejection, chronic chronic rejection, which we don't do very well, that does not respond to treatment very well. So that will lead to graft failure long-term. And then the allogen independent has to do with ischemic injury. If it is an older age donor, that kidney is gonna last, not gonna last as long as a younger age donor. CNI, unfortunately, CNI are great when it comes to preventing rejection, but then they, as I told you before, it causes nephrotoxicity. So being on the CNI also contributes to the late graft failure. And then the regular diseases, diabetes, hypertension, infection like BK virus, proteinuria, all of that contributes. The patients may develop graft failure because of drug toxicity, like the CNI or other drugs. They may develop recurrent disease, like recurrent diabetes or recurrent glomerulonephritis. There may be a new disease, like a de novo glomerulonephritis or some other cause of their graft failure. And then finally, it could be secondary to rejection. So there's multiple factors that contribute to late graft failure. So these are the reason why we're not doing so well for late. We're doing excellent with early graft survival, but not so well with late graft survival. So immunosuppression may have an early benefit, but then they have late adverse effect on graft survival. So like I said, the CNI toxicity. Late graft failure can occur be a mechanism unrelated to immune injury, so CNI toxicity, recurrent disease, senescence, and then immunosuppression may be inadequate late. So what happens is at the beginning post-transplant, we keep them on very high dose immunosuppression. Then over time, we decrease their immunosuppression because of risk versus benefit. And we also follow them very closely. During the first year, we follow these patients very closely, but then after a year, we extend the visit. We don't see them as often. So we may not be able to identify a rejection early, either because they were non-adherent, or maybe we ourselves minimize the regimen, and then they may develop a rejection later on that we may not be able to identify it on time to treat it. So they may develop subclinical rejection, late acute rejection, and antibody-mediated rejection. So if you have a patient with a transplant that comes with allograft dysfunction, you have to in some ways approach them similarly to any other patients with AKI. You need to rule out prerenal factors, dehydration, hypotension. You need to look at an ultrasound to rule out obstruction or renal artery stenosis. Look at their CNI level. Maybe they have very high CNI levels. Maybe they were started on a medication that inhibits the metabolism of the CNI, and the CNI comes very high. So take a look at that. And then if all of these are ruled out and it's still high, we may do a kidney biopsy, to rule out infection or rule out a recurrent or de novo glomerulonephritis. And then they may also have a viral nephritis. So you should always check like a BK PCR, CMV PCR if they come with allograft dysfunction and you have ruled this out, you need to check this because it may be related to that. However, if that is the case, when we do the kidney biopsy, we'll be able to identify this as well during the biopsy. We'll be able to rule it out. All right, so this is our staff. We are 6 nephrologists. There's 6 transplant surgeons that do kidney transplant. If you guys have any questions about referring a patient, or would like to get an expedited appointment, you can send us an email directly, feel free. We're actually changing our, the renal elective is changing. So before you guys were doing mostly just general nephrology and you were not rotating through transplant. So now we've Dr. Azzi and Dr. Azzi is going to be in charge of the residence elective, and I'm going to be in charge of the medical student elective. So you're going to get a chance to do 1 week rotation in transplant if you do our elective, and then you'll do the rest of the time in general nephrology, but you'll get to spend time in the clinic and in the dialysis unit. So we're doing a more broad experience, so you get to experience everything that nephrology has to offer to you guys. When it comes to the transplant elective, you'll get to come to clinic with us And you'll get, if you're interested in seeing how a transplant is done, how it is performed, and you're interested in going to the OR, we can also arrange that during that 1 week elective. So I think that's it. If you guys have any questions, feel free to ask.